In neuromuscular, you have, as the name suggests, neuro and muscular, you have starting from the upper motor neuron, that is cerebral palsy, to brainstem injuries causing scoliosis, to poliomyelitis, muscular dystrophies, spinal muscular atrophy, all that, which will come in the neuromuscular type. And you have the syndromic variety where there will be all these syndromes where you see connective tissue disorders, your Marfan's, Prader-Willi syndrome, all that will fall into this category of syndromic variety. Even the spondyloepiphyseal dysplasias will come under this syndromic variety. And if you don't find any cause, then that will fall into this idiopathic variety. And there are two types of idiopathic variety as well. If the onset of curve is below, before 4 years, then it's infantile, and juvenile it is 4 to 10, then it is juvenile. So what is the main goal of treating these kids? There are two main goals here. One is, the priority is to maximize the growth of the spine and the thorax by controlling the deformity as well. And by this, you will be promoting normal lung development and pulmonary function. So the main goal or the aim of treating these kids is to maximize the growth of the spine and the thorax, by which you will be uh, promoting the normal development of the lung. So growth of the spine, the average thoracolumbar, that is T1 to S1 growth, is about 10 centimeters in the first 5 years of age, about 2 centimeters a year. And then between 5 and 10 years, it's about 5 centimeters, which is 1 centimeter a year. And from 10 years to adulthood, it is about 10 centimeters, that is again 2 centimeters a year, which includes your adolescent growth spurt as well. So when you look at the pulmonary development, the first 5 years of 4 to 6 years is very crucial. You see the graph where the green line, you can see that that's your mean lung volume, and this is the alveoli, total alveoli. So if you see here, the first, it peaks at 4 to 6 years and then it plateaus down. Even before, like in the formation of alveoli, at birth, if it is, they say it is 20 million, and then it goes up to 300. So this is, sorry, this is the pulmonary development we see in the early age. So if there is a curve and then there's a compromise on the thoracic cavity, then compromises on the lung volume, and then you have the restrictive lung pattern and this thoracic insufficiency. So as you see here, so the lung function studies show in these kids show a restrictive pattern with small lung volumes, with reduced chest wall compliance and respiratory muscle dysfunction, which will lead on to what is called as a thoracic insufficiency syndrome, where the definition is the inability of the thorax to support the normal respiratory function and the lung development. So this is what happens in these kids with early onset scoliosis. So coming on to the history of treatment. So what are the strategies which was followed? Casting and bracing comes first, and then this has been the mainstay before the era of spinal instrumentation. So they have been casting each and everything. They do not know what to cast and what to, because there's no other option. So they have been doing that for ages, and then they felt that the cast itself deforms the ribs, and then the techniques were not evolved. So they had to discontinue that. And then came Harrington, Paul Harrington, who introduced the rod system in 1960s. So it's a very straight rod. He introduced this kind of distraction. It's a single rod which goes top to bottom, and then there's a single stage distraction. The spine is distracted and kept on a two-dimensional plane. If you see, it causes flat back, and then it led on to implant failures and all that. So it was finally discontinued. And then came an era where they practiced early spinal fusions. They thought that a short, straight spine is much better than a crooked and a progressively worsening spine. So they fused all kids at 7, 8, and 9 years, and then they found that there were premature deaths because of this thoracic insufficiency syndrome. So, with all these things, then came this growth-friendly techniques. So, what we will be looking at today is mostly about these growth-friendly techniques because we are there right now. So, before we go into that, we'll just quickly run through this. Casting and bracing still holds good for one type of uh, early onset scoliosis, which is the idiopathic variety. And as you all see, this lady, Min Mehta, is a pioneer in casting techniques. And in the 1970s, she has shown that up to 70 and 90% of these idiopathic curves can be treated only with casts, and then they can have a very good result. So she brought the significance of what is called as rib vertebral angle difference, which is this one. So she said that if the rib RVAD is 20 degrees or more, it's considered progressive. And then she started casting, and this is the COBS, more than 25 degrees and more than 10 degrees of documented progression. Then the casting is done under general anesthesia with the patient on traction, on suspension, suspended, and then derotated and then molded. So usually it is done about every 8 to 12 weeks, about 2 or 3 months, and then they went on to brace after that. And if the curve is less than say 20 degrees or 25 degrees, you can straight away go for a brace, and you can have the brace for about hello, you're audible?
Yeah, Dr. Prince, you're audible. Yes.
Yeah. Hello?
Yeah, Dr. Prince, go ahead.
Ram, can I proceed?
Yeah, please proceed.
Yeah. Braces are often used to maintain correction sometimes, or to delay the surgical intervention. Sometimes you had to brace. So this is one such patient who had casting. So if you see here, there's about a 40-degree curve which has come up to 18 degrees. The child will be happy with the cast on. There's a cutout for the abdomen, and that's the technique which was shown by Min Mehta. So growth-friendly techniques came into vogue because of the modern implants, we should say. And these implants attempt to this is the goal we had in the previous slides, to maximize the growth, controlling the curve progression as well, by which you preserve the normal lung volume as well. So growth-friendly techniques, we divide them into 3 techniques. One is distraction-based techniques. Number 2 is growth-guided techniques. 3 is compression-based techniques. We'll see one by one. Distraction-based techniques, we have 4 varieties how we do it. One is traditional growth rods. Number 2 is Vector, or we call it as vertical expandable prosthetic titanium ribs. Number 3 is hybrid. We use both Vector and growing rods together. And number 4 is a magnetically controlled growing rods, or what we commonly call it as a magic rods. So we'll go one by one. Traditional growth rods. how they do it. Here they have to have a proximal and a distal anchor. So it can be a hook based or a screw based system. Proximally, usually they use the hooks, a downgoing TP hook or upgoing pedicle hook, or sometimes they use rib hooks. Mostly in kids, we use TPs or rib hooks, and then you you have pedicle screws lower down of the curve. So you have a proximal anchor, a distal anchor, and then connected by two rods. There are growing rods with single rods also mentioned. I'll show some of the examples. But usually we use two rods, and then the limited fusion at the level of the anchors where you put the screws or the hooks, you fuse that area and start distracting them. So the distraction is by, sorry, then you connect the rods with connectors, or what we call it as dominoes, which we have end to end or side to side. Then typically you lengthen every 6 months. Agpanya has the largest study for the growth rods, and his results show about 80-degree corpse has brought down to 36, and the average growth is about 1.2 centimeter in this study with 4 years follow-up. So this is what I was talking about. Anchors, this is one anchor, this is another anchor, this is the proximal anchor, this is the distal anchor. You use the hooks here, use screws here, you fuse this level, this segment you fuse this one, and then here they have used a connector which is end to end. You can use even telescopic rods like this. You have a stop, you fix it, and then every 6 months you open this up, distract here, and then lock this. So this is what is called as traditional growth rods. So here you see a unilateral or single growth rod. So what they have done is they've used what is called as a domino. So this can be opened at 6 months, loosen the domino, distract it, tighten it, and then you keep doing it every 6 months to gain the length. So this is one such case where you see a 62-degree curve is brought down to 34 degrees on serial X-rays. But if you look at the rotations, it comes back or it winds back. So it's basically, it doesn't control much of the rotation, these traditional rods. Then we'll have a quick look at what is Vectors. Bob Campbell is the one who introduced this. These are again titanium implants. It looks something like this. So this is a vector. So you have a hook system here which hooks on to the ribs. If you think that the ribs are not resilient enough for your distraction, or is it not strong enough, then sometimes they extend it onto the spine, or sometimes even to the iliac crest. So vectors are generally thought it will improve the pulmonary, that is for the ribs, but sometimes in reality this thoracic and the thoracic cavity and spinal deformities are closely linked, that even you can bring it to the anchors, it can be brought down to the spine to get it corrected so that the thoracic volume increases. So this is particularly useful if you have fused ribs in the case of congenital varieties where you cut in between the ribs and distract it. So vectors also have shown good results depending on the technique and how you use it. So this is one such example I wanted to show you. So that's how a vector looks like. So suppose if it's a very small child and you can't even hold it on the spine, then you distract it against the iliac crest. There's a hooks which goes into the crest, and then this you can tunnel this down. The whole device you can tunnel it down and then fix it there. Then comes what is called as magnetic growth rods. These are rods which have an internal magnet. These are all telescopic rods which has an internal magnet. But the technique is the same. You have an anchor, same anchors in the top as well as bottom, the proximal and distal anchors. And then here the advantage is you can use frequent lengthening. Like because it's non-invasive, you can even lengthen it every 3 months or so. And then see, this study has shown this. Still, it is not widely practiced, but within a limited time, whatever study we could get from the literature is this. So, about 20-degree change in the curve, and then you see approximately 5 distractions for 15 months. That means every 3 months they have been doing it, and then they could gain a length of about 3.5 centimeters, which is really good for a kid with early onset scoliosis. Okay, so how this is done? This is how it is done. See, again, the anchors are the same. You need to have good anchors for all the distraction based techniques. You need good anchors. The problems will come with the anchors, the complications. So you need to have a good anchor. You need to get it fused and then start distracting. So this is how a magnetic rod looks like. There's an internal magnet inside, and you will have something like a circular magnet intraoperatively. Before putting the rod, you can just insert it inside and see whether the actual lengthening happens, because you always test it before you put the rods inside. And you have to be very accurate in placing the rod, and also cutting the rods, because it's very expensive. About $4,000 it takes for one rod. You can't be like changing the rods after you cut the rod. So you have to be very careful in that. So the technique is the same. Here you use the hooks, upgoing hooks for the proximal anchor, and then they have connected it, and then you start distracting on OPD basis. They don't have to come to the theaters. The nurse does that. Okay, so it's only this machine which goes in over the spine, and then you have a button to press, and that's it. On a magnetic field, this opens up. So you can see here it's opening up here. That's how it expands, and then the curve gets corrected. So having said all these things about growing rods, vectors, magnetic rods, and all that, they are not without any complications. They do have complications like anchor malfunction, pull out, erosions, rod breakage. Distraction based devices are criticized for the kyphosis, because if the you imagine a proximal anchor and a distal anchor which are fused, now you start distracting. If the anchors are fused well, then sometimes it goes for kyphosis, because you are doing it in a two-dimensional plane, the distraction. And if the anchors are not fused, it pulls out. So that both can happen. Complications can happen. So, and they say that every time you go in and distract, the the length what you gain is less and less. So what is called as a law of diminishing returns. So every lengthening you see that 0.25 millimeters are becoming less. So usually you lengthen about a centimeter or zero point 0.5 to 1 centimeter depending on the growth rate and how much you will be able to get in one lengthening is about a centimeter. And if you're doing it often with magic rods, then you can do it about 0.5 centimeters every 6 months or even 3 months. So they say that the proximal rib anchors, the hooks are better because they are less rigid. So pull out is not common with hooks. And then because of repeated surgeries every 6 months, deep infections, sometimes they go for autofusion, and there are some psychological effects associated with multiple surgeries. Of course, new technologies like the magic rods have minimized all this complications of distraction techniques. So these are the complications. You can see a rod breakage here, the pull-out here, and then sometimes it becomes very prominent. These kids are not very strong and well-built kids. They're all emaciated, sometimes thin-built, except for the syndromic varieties or the neuromuscular kids. So next one is the guided growth techniques or self-growing rods, they call it as sometimes. Again, it's all started with Luke Trolley years back, where um, you see something like this. So what he did was, the convex side, he arrested the growth by doing um, epiphysiodesis, that is fusion of the end plates, and then he used wires to hold the spine. So it doesn't work sometimes because it causes a tethering effect after some time, because you fuse it for a long segment, and then there's not much um, growth afterwards. So that was discontinued after a while. Median had a system with H rods. He has got a larger series. There's a guy from Nottingham who has got this series. I'll show some of two of his cases for you to understand how it works in his hand, and it's a good system. And then he has changed over to rods and screws with wire construct after the introduction of the pedicle screws and stuff. And there's another new system which is a technique, which is a Schiller technique, again using the pedicle screws and rods, which was introduced by Richard McCarthy. So these are the techniques, these are the systems used in these guided growth techniques. We'll see one by one. So what is a Schiller technique and what is H bar or a median system, or what is a hybrid construct? See, if you see the Schiller technique, what they do is they fuse the apex. Previously in growing rods, we saw that they fuse the anchors, proximal and distal anchors. But here in Schiller technique, what they do is they fuse the apex with pedicle screws and two rods going on. You do have anchors here, but here the screws won't be locked. It's just over there, and this is sliding. So once you fuse this, whatever growth happens is on either side like this. This is a, again a growth guided technique um, introduced by McCarthy. And then this one H bar is not in use now, but is shown good results. So this is, um, I think I'll have some pictures of that in the next few slides. I'll show you. But these are basically two rods, and then you have the H connectors in between. So you do anchoring or fuse this area, but either this goes into the iliac wing, or there are two sacral screws which goes into the S1 or L5 sometimes, and then you fuse this base, and then you tower it up with two rods connected with the connector, and this connector can actually slide, and through the lamina you pass the wires, and then you connect at all the levels uniformly, so that the growth occurs like this. And as the growth occurs, what happens is this H progresses out and then it falls out sometimes. So that is another technique. So I'll show you some cases of that. And then what is called as a hybrid technique. With the advent of pedicle screws, more and more this technique is followed. you do have proximal anchor and distal anchor. Fuse them, and then, sorry, what happens is here you have two rods. You don't have to lengthen every time. You just have to use the lamina, bring the curve into this rods, and then tie it. So as the growth happens, what happens is it grows slowly, and then the rods will slide, and it will come out of every wire as the curve or as the growth happens. So I don't have to talk much about this because this is not in use and then it has fallen out of place. It's like the Harrington rod which went out of place now. So we'll go for this example. This is a median system H rod. You can see that neuromuscular type. Here you see the progression. So about at 4 years of age, see here, in 97 he has done this 30-degree curve. So what he has done is, this is the head system. It has gone inside here, the base is fused, and then we cover it up. At every level, because these curves are much flexible, like the neuromuscular scoliosis, you have a long C curve, sweeping curve, they call it as. Bring it to the midline, and then every lamina is both sides. He has done this. And you see the growth at 9 years and 10 years. See the H is here, it has fallen out here. And then this is the system he has used. And see this post-op 13 years, 12 centimeter growth, no PJK, proximal junctional kyphosis. Thoracic kyphosis and lumbar lordosis is maintained, and that's just one surgery. So it has worked well with him, and he has moved on to the screw rod system after introduction of the pedicle screws. You see here in spinal muscular atrophy, this is another kid, again with a C curve, something like a C curve. See the posture significantly improves, even though the child is a non-walker. Okay, you see here the proximal and distal anchors. You get the wires like that, and then use the rods and then tie it up. The correction is pretty good at day one, and then it the curve doesn't progress at the as the growth happens. It just slides. That's how it is. So one wire is out now, so it keeps sliding as the kid grows. It keeps sliding, and you gain the length. So that's another technique of guided growth. Again, the same technique used for a idiopathic scoli, which is not correctable with braces or casting. So much smaller instrumentation here, stopping at L2, and then it goes on. So we'll go to Schiller technique. So as I said that here what happens is you fuse the apex. So you instrument the top, bottom, and the apex. Apex is fused, the red arrow here, and then here it is not fused, it's just left alone. The rod goes into the tulip to put the um, locking nut, and then you don't tighten it, it just has to slide. So as the child grows, you see the rod here, you don't see the rod here, so the growth has happened. And slowly this way also, the growth happens both this way and that way, both above and below, and then it slides. That's the technique of Schiller. So another case to show you. So you do Schiller for patients you want to correct the apex. Suppose you have an acute curve with the apex which is rotated and tilted. You want to bring it to the midline. You do that Schiller, and then leave the top and bottom free without locking it. So it guides the growth, and then you get a fairly a decent result at the end of the curve. Then comes what is called as compression-based technique, which is the third technique, which I'm going to show. Still evolving because compression-based things are not these temporarily stopping the growth of the convex side, but you don't fuse it. Sometimes people confuse with fusing that. These are non-fusion techniques where you do the to stop the growth of the convex side temporarily by using staples or tethers, but staples are no one is using now. Mostly they're using what is called as tethers. These are all newly evolving techniques, and these are all anterior surgeries, anterolateral instrumentations, anterior approach lateral instrumentation, anterolateral tethering it's called as sometimes. And because of the anterior surgery, they say that sometimes if it is an open procedure, that itself affects the pulmonary function. So more and more of thoracoscopic assisted they are doing with mini open techniques, and there is a possibility of overcorrection with these techniques because once you put the tethers, you achieve the correction, and because there's tether on the convex side, the concave side, if there is a lot of growth potential for the child, say suppose you're doing this for an 8-year-old child, then about 12, 13 years, they overgrow that, and then the curve tilts to the other side. So these are all potential things which is possible with this compression based techniques. So if you see here, so thoracic curve has been managed with the tether. You see here, 40-degree curve has straight away come to 12 degrees. The temptation here is to correct the deformity at one go because it's a powerful tool. This crimping, this one, it works as a crimping mechanism where by pressing this one, you tension the cord and then you lock it. This is something like your final tightener, right? So if you start doing that, then you get an absolute correction, faster correction. But very soon the concave side overgrows, and then you will have a curve tilting to the other side. So an ideal case should be something like this, where the you see here there's not much correction here, but as the child grows, you see gradually correcting. You see all these screws are converging. Here it's all diverging, and this cord is nothing but what you see is a multi-braided. Um, if you have seen arthroscopic anchors, they use something like material is something like that. So I was I saw a couple of cases being done, but the thing is we don't have much follow-up. I do not know how this behaves, but latest studies by Peter Newton and others have shown that it has to be used very judicially, and they don't recommend for kids below 10 or 9 years because there's too much of growth potential to it. And if at all you're using it, sometimes if your correction is achieved, then you may have to do a thoracoscopic release of the tether so that you get the curve, and then the recurrence, which rate still we do not know whether it can happen or not. And then a quick note on congenital scoliosis I want to talk, because this congenital scoliosis is the only thing which you can go for a definitive fusion at an early stage, and that is a limited fusion. It's not a fusion top to bottom. So that's why I am just making a note on this. So again, types I don't want to go through again. So you know that there is a failure of formation and failure of segmentation, all that. These incarcerated and non-segmented hemivertebrates does not progress and does not require surgical intervention. All that requires surgical interventions, or a fully segmented hemivertebrae or a wedge vertebrae, or even if the hemivertebrae is, if you have a fully segmented hemivertebrae on the other side, I don't think we need to have surgery done. You can observe these are the things which straight away you know that it's going to progress for 30, 40 degrees in another 2 or 3 years, and then you need to get surgery done. Similarly, the bars, this unsegmented bars, and then unsegmented bar associated with the hemivertebrae is a disaster. So all these congenital varieties have associations with cord, something like a syrinx or a Chiari malformation or a tethered cord or diastematomyelia, all that. It's about 26%. MRI studies have shown that about 26 percentage of these variety congenital varieties have the abnormalities. So these are some of the pictures I've shown to Chiari malformation here, or a diastematomyelia with a bony bar here. You can see all that. So hemivertebrae, if you see something like a hemivertebrae which is single, a sharp angular deformity, all you need to do is excise it, crunch it, fuse it. So this is what most of them do. Suppose sometimes you can have a kyphosis associated with it if the formation is defective anteriorly, then there's a kyphosis. At that time, you may have to do a front and back surgery. So most of the time, you can do from the back. You put the pedicle screws. This is the cranial end, this is the caudal end. You excise, take a wedge out, crunch it, and then fuse it. So this is another example here I've shown. So, so if suppose if you're not, if you're seeing something like this, hello, Ram, you can
Please,
hear me? Yeah,
please go ahead.
yeah, yeah. So if you see something like this, a congenital variety where there's a fusion bar there, unilateral fusion bar with fused strips and all that, a 7-year-old, 6-year-old girl, you can't do a fusion straight away, right? No way you can go get a fusion muscle. So all that you need to is guide the growth. Just use distraction-based devices rather than guided growth here, because you want to distract and get the thorax volume of the thorax back. So this is how you do it. You do anchors, distract, get it into uh, acceptable growth and the thorax, and then you can do a definitive fusion once the child is nearing maturity. So having said all these things, if I'm not going to say something like a take-home message, then again, you do not know where the road goes, right? So I thought I don't have a um, definitive protocol or a algorithm to say you do this, that, but I would suggest these things based on the experience, what I've seen. So if you see a congenital early onset scoliosis, if it's a single or a wedge and double wedge or a hemivertebrae, you do an excise, you do excise and do a limited fusion. So something like this. If you see it early like this, it's an infant. You see a hemivertebrae here. So you know that this requires an early limited fusion. So when can you do it? So about 2 years, ideally between 3 and 4 years, but even people have done it at 2 years, then it's a local problem, right? The curvature happens because of that. So you tackle that way. Again, I said more than 3 segments bar, then you know that there's um, um, it, it's not feasible for a limited fusion, especially in the upper thorax or mid thorax. And we have to do something like this patient. Someone comes to you like this, 8 years old, you can't do a fusion, right? So you have to do something like a anchors and distraction, and then go for a fusion later on. If you see few strips like this, then vector. Maybe in our setup we can't do a vector. You use growing rods again. use hooks here in the thorax on the ribs, and then you get anchor points here in the distally, and then use growing rods. That's what I would do. Then comes neuromuscular. You try casting up to 40 degrees, because until the child is 4 or 5 years, you can try casting, because that's to buy time. And definitely they're going to, if a curve is like this, you don't want to use a growing rod, or you don't want to do a surgery right now, right? So you can as well do a casting and then buy time with braces and all that. And if it goes beyond 60 degrees or like this, then definitely I would use a growing, self growing technique, like how we use anchors and rods and wires, so that there's one surgery and then the growth will be guided along the path. Syndromic varieties, again, bracing initially to buy time. If you find it is progressive, then we have to use other techniques. So supposing like this, a curve, it can be braced and we can wait until you know that the progression is happening. Or if it is a curve like this, it's a double curve, and then you can use a growing rod, basically a guided growth technique. A growth, something like this, you want the apex to be corrected, then you want to bring it to the midline, then you use what is a Shilla technique. Put anchors up and down, don't fuse them, fuse the apex, and then allow the growth to occur. Idiopathic variety, infantile, you don't lose anything by casting, casting and again casting until it stays there. Rarely it requires surgery. Juvenile variety, where you see the curve occurring above 4 years, and then if it shows RVAD of more than 20, or if it's progressing, then you use guided technique. Like suppose a curve like this, idiopathic variety, you still can wait casting and then bracing. If it's something like this, then you would definitely consider surgery. But with the brace, you see it's getting corrected, but still the balance, you can buy some time, and then same, you do a distraction based technique, growing rod, magnetic rods, and at maturity you can take out the rods and then fuse it. So this is what we have to do. So hope, I think I've given a comprehensive idea of what it is, and I thank Ram and all of you who have listened to me patiently. Thank you.
Yeah, thanks, Dr. Prince. That was an exhaustive topic. Actually, we asked to cover within half an hour, but you have done the job perfectly, and you have given almost an overall view of techniques
Yeah.
of dealing with early onset scoliosis, everything together. These topics are not that common in any of the centers, and it's like in tertiary that they used to manage. But I wanted each and every participant to know the overall view of it. And I request the participants, if at all any questions are there, to raise. Yeah, I think Dr. Yuvraj wants to ask, but Yuvraj, go ahead.
Thank you, sir, for the great talk. It was
Yeah,
very comprehensive and well presented. Thank you, sir.
thank you, Raj.
So I'm just going to ask something that's little off the mark of what you talked today. It's about counseling these patients before you start them on the treatment, because it's usually these are very long duration treatment. They have to be on follow for a long time until multiple surgeries, etc. So how do you tackle them? So when you first diagnose, once you start initiating the treatment, so any tips on counseling these patients and the parents?
Yeah, definitely. Counseling is a important part in the treatment. Parents need to know they're already depressed with a child, especially with a neuromuscular or syndromic child. They are overworked with all their nursing care and all that. Most of them will be on the wheelchair. So these techniques and all the surgeries, what we do, the repeated surgeries sometimes puts them off. So we have to have a good counseling unit. Social workers do it abroad, but I think it's the doctor's role here to sit with them and empathize and then talk to them. So that's important, as you mentioned it. It's not that often we do it here because the mentality here in India is you think one surgery, one result, and then child is good after that. So we need to sit with them and then make them realize this goal is not achieved in one day.
Thank you, sir.
Yeah.
Yeah, Dr. Ramakrishna.
Yeah. Hi, this is Dr. Venkat Ramakrishna.
Hello.
It's a very good talk. Thank you for the talk. And I have two doubts regarding the same. So, early onset scoliosis is actually very challenging. It's not like a routine idiopathic AIS. So, however, the usual definitive fixation is avoided because of the crankshafting. And as you said, it's restricting the growth and all. And whenever you do taking the anchor points without exposing the complete this thing, so how many days would you wait for the anchor to set in to put a destructive rod?
Distraction.
That's one question. And second thing, if you're exposing the whole thing, it's known that once you expose the spine, it's as good as fusing it in early onset patients. So have you seen any crankshafting after the complete exposure of the patient?
Yeah, the thing is, for answering your first question, we put the rods on the same time. Only thing, we don't start distracting. So you put the anchors, screws, limited exposure of the top and bottom. You tunnel the rod subcutaneously and place the rod and then lock it. So the first distraction will happen at 6 months' time when you are sure that the fusion has occurred, or you can't make out a fusion in an X-ray, but at least you have to wait for 6 months until you do your first distraction. I think that answers your first one. The second one you asked was regarding the crankshafting. So crankshafting is less if you use the techniques like Shilla and then um, magnetic rods, because most of the time what happens is if you expose the muscles um, from subperiosteally, like the entire length, then that goes for fusion, auto fusion. So we do have seen crankshafting. I have seen something like when you start distracting it on the third distraction, sometimes you won't be able to distract even zero point 0.2 or zero point 0.3 millimeters. That's when you know that it's going to fail. So that's when you know that the next time you distract and to do it through lateral view, and you know that it's in kyphosis. So it does not work. So that's how it is.
Okay. So what precautions should we take while doing it to prevent the crankshafting?
Mostly the dissection. If you have to do a growing rod, you don't have to dissect the entire length. In Chilla also, they are very careful when they do the apex. They do the very limited exposure of what they want exactly to fuse, and then don't do any much exposure which is not required, because every level you expose, you are risking of autofusion. And the most important criteria here is submuscularly. You have to do the subcutaneously the rods submuscular. For the fascia, you have to tunnel it and then fix the rods. Those are the things you use.
Okay.
Yeah,
Thank you.
There are certain questions that has been asked in chat. So, next question is, when do you use an single rod or double rod?
Single rod, double rod. Mostly people have started using double rods now. Sometimes they don't distract the other rod. So if you see an example like this, So see here, you can do it with a single rod, but for the overall balance, they have not distracted this. They are only distracting this. Here they don't use uh, double rod for a distraction. Uh, for distraction, they are just for the support. You don't want the balance to be lost. So most of them now use double rods. I have not seen long series where they use single rods now. So double rods are good enough now.
And
Is that okay?
yeah, that answers the question. So now it's mostly the double rod which is being commonly used. And one question from Karthikana, he is asking, when do you offer surgery? Earliest possible. And is there
Sorry, I didn't get your question. When do you do the surgery?
when is the earliest you offer surgery based on the age and curve degrees? That's what his question is.
So it depends on the usually general, as a general rule, about 40-degree curves at 3 or 4 years. You try to get, see, to put the anchor points, you need some good bone stock there. So if it is a congenital variety where the ribs are fused and then they are not going to um, you're not able to get correction with cast, then as early as 2 years you may have to do surgery. As early as 2 years means to do a vector or a distraction technique, you have to use some anchor points and then do that. But generally 3 or 4 years, the time when you think of using uh, surgical intervention on a patient, like a growing rod or a self-growing techniques, guided techniques, all that. And cobs, I won't say it's a fixed thing, but generally up to 40 degrees you can maintain well on a cast or a brace. Beyond that, I think you should think of surgery.
I have a question.
Gurudev, Gurudev.
Yeah.
Please,
Yeah.
some
What
problem.
were the problems with Sila system? I mean, it looks very attractive concept. You only operate
Yeah.
once, but why didn't it become so popular as growth rod?
Sorry, Shilla
Gurudev is
technique.
asking
Why
about
why
Sheila.
do you think it became popular? You're saying?
No. Why it did not become popular like growth rod?
No, growth rod has got a longer series. People have been doing it for now about 20-30 years now. Shilla is last 10 years. So I think it's not that the advantage of Shilla is you can really get the apex corrected. The rotation comes back and then you fuse that part and then allow it to grow, right? With all these systems, whatever it is you use, or distraction systems or all that, the complication rates are the same. Even for the Shilla, the pullouts, the um, growth potential, all that, if you compare, it's about the same. But still, distraction devices are taking, even if you ask about in group of people who are doing this early onset scoliosis, 50 to 60% of them go for growth rods or distraction techniques first, because they know that they are able to achieve the distraction at the thoracic level to get the thoracic lung volume. This is essential for a congenital or a patient where you need a lung volume to be corrected within 5 or 6 years. Say if it is a neuromuscular curve or a muscular dystrophy which has got um, no bearing on the direct bearing on the thoracic volume straight away, that's when they do this guided techniques. That's what I have observed. So if it is I think that is the place where we have to draw the line and think that that's why they think of distraction techniques more than Shilla. That may be the reason that still that's your question, right? Why it has not become more popular than the other ones, right? So
Yeah.
for a limited amount of time, for a shorter duration of time, you want the lung volume to improve the thoracic cage, then I think distraction works better than Shilla.
One more question regarding Sila. I mean, we can use the same, I mean, the rods we normally use for our cases, or like it's a special kind of rod?
No. The same rods. There's no special rods for Sheila. It's the same rods, and you don't lock it. That's all. So it's the same 5.5 rods what we use for normal system.
Yeah. Dr. Shiju, are you there? Dr. Shiju Mujin? Okay. Dr. Guru, want to add up something? I think most of the times, like when the degree is more than 60, I don't have much experience of early onset scoliosis apart from congenital, but yeah, places where they teach, they say more than 60 degrees is the one which most of the times needs surgery, and less than 60, better is to cast or brace. So delaying surgery, this is most important because it's like delay as far as you can. When the curve is more than 60, you go for surgical options, and less than 60, you always try to not to have to maintain them with bracing and casting. Better will be casting rather than bracing.
Yeah.
Am I right?
Yeah. You're right. Probably if you know that it's going to progress at that time, 50 and 60 degrees curve, you think of doing an intervention.
Yeah, more than 60 cut, less than 60 cast. Dr. Guru?
Oh, sorry.
Yeah, I want to ask few questions.
Yeah. Hi, sir.
Hello,
Yeah. Hi,
do
sir.
you hear me?
Yeah.
Audible, sir. Audible. Go ahead.
Hi,
Audible. Yes.
good evening, Prince.
Yeah.
So the Shilla technique, there is a central anchor and a
Yeah.
proximal and a distal screws are there. No?
Yeah.
So that is special screws, or is routinely we use pedicle screws?
No, it's a routine screws. Your same screws what we use
How do
for.
you how do you make it? Because sometimes that nut may come out. No?
Yeah, the thing is, they say that you don't have to completely lock it like how we do it as a final tightening. The
Okay.
thread goes
Mm-hmm.
into it, but you don't lock it. So then it slides.
Mm-hmm.
Usually the systems what we um, the local systems, I'm not sure, but Medtronics and other systems like Globus and all, they don't come out. So usually, if you do it with an opposite turn, it goes, and then once, if it is correctly fixing into the um, threads, then only it will go in. So don't go in just like how
Mm-hmm.
we sometimes cross threading we have seen, no? With local implants like Jayan or Disco. It doesn't happen that way in Medtronics or Globus. So it usually goes inside, sits nicely, and yeah, whatever I have seen, they use the same thing. They don't do the different screws or anything. It's the same screws.
No, what I'm asking is because repeated there will be some movement in the rod and the screws because it is loose. So sometimes what I was thinking that nut might come out unless you lock the rotation of the nuts. I'm not saying that lock the rod unless you lock the nut rotation of the nut. At the same time, you keep the rod loose within these screws. Is there any
Yeah.
special screws available like that?
No, I have not seen such screws, sir. I have not seen such screws.
Okay. So one more question is that you have shown me on that wiring technique. The proximal and distally you put a screws
Yeah.
and
Yes,
you
sir.
put a anchors, and
Yes,
in
sir.
between you put a sublinar wires.
Yes, yes, sir.
Where if you see that pictures, there's a complete exposure of the lamina, including the subperiosteal distribution.
Yeah, yeah.
So what is it the I do expect some fusion in that case. If
Yeah,
this completely
yeah, exactly. So these are all not the cases. I've shown what are the cases. This done by Median. So these, I think these are the ones you're talking about. The exposure, as you say, that they have did a complete exposure. But to do this, that in his series, what he has shown is there's not much autofusion happening. There is growth, and then whatever he has shown here, I'll show you some of the pictures. I think it has
So what is the average age he has
average
performed? Average
about
age.
about 11 to 13, whatever
Okay.
is seen here.
Because
It's
10
about
plus,
13.
that's why it's not happening.
Yeah, yeah, probably, which we do
It's,
not know.
okay.
But
Okay.
I thought this is a good technique. I have not done this personally here. We have not seen here, but it works for him. That's what he has shown. Yeah.
Hello.
Any other? Yeah.
Yeah, hello. I'm Dr. Shiju Majid. I'm from Trivandrum.
Yeah. Hi, sir. Yeah, tell me.
Yeah, hello. I'm from
Hi.
Trivandrum Medical College. Nice presentation. You summed up everything nicely.
Yeah. Thank you.
My experience with is limited. Maybe I have done around 25 to 30 cases over the last 10 years. Over a period, because these cases are also rare. No, also
Yes.
number is usually much less than your AAS cases.
Yes. Yes.
There are few points that we have evolved over a period of time. Our team.
Okay.
One thing is that
Okay.
the crucial point for a growing rod or whatever early onset treatment is always the proximal anchor.
Yep.
Because we started initially with the hooks and system, but we have gradually moved away from the hooks because of the so many problems that we tend to face with the hooks.
Okay.
With the dislodgement of the hooks, and usually these children are very thin also.
Yep.
So at the tip of the rod protruding through the skin, that is another problem. And if the patient has got a significant hump also, you have a lot of difficulty in putting when the convex rod is contoured. Usually that also will cause a painful area as the child grows.
Yeah.
So nowadays we are particular to put a pedicle screw in the upper proximal. We put three levels, three
Okay.
adjoining
So
levels.
I've gone back to pedicle screws rather than using a hook
Yes.
system.
No,
Yeah.
we have gone back to pedicle screws, but the thing is that that the end of the rod that is going to the upper three pedicle screws, we try to create almost a soft landing of the rod. There is no acute bend or anything, so
Okay.
that
There's not much stress there. That's what you're saying.
yes, so that even when you distract later also, there is no abnormal junctional kyphosis. The chances we feel is lesser
Yeah. Okay.
when we contour the road in such a nice way. Then
Yeah.
then we also put a transverse connector at the proximal between the three proximal screws.
Yeah.
That area, the
Usually,
the upper basement.
yeah.
So that
Point.
the chance of, even if something is getting pulled out, that amount of pulling out will not be there.
Yeah. Point is well taken, sir. So
Because,
people have. Yeah. Most of them prefer. They say that the hooks are better in terms of, as you said, soft landing, or stresses are less. But if you think that the hooks are failing because the stresses are more, then I think if you have three screws, pedicle screws, that's a good enough anchor. And as you said, rod contouring is a very important thing. You don't have to have the excess kyphosis there to get into the normal, thinking of getting a normal dorsal kyphosis. So that is a point to be taken. Yes, sir.
Then one more, these are things that we have learned through our mistakes, maybe improving on our own cases. Then one more thing that we are trying these days is, see, our problem is always to get these children at the right time to get a repeat distraction over a period of time.
Yeah.
Due to various reasons, due to financial reasons, due to our time constraints. I work in a public hospital, so all these problems are there. And people want to have minimum number of exposures for to surgery. So what we are trying for the last couple of years is that we lock one of the we use the Synthes domino connector. So all our early onset scoliosis I use only the Synthes system because we are familiar with the system and we are confident with the system. There is no, I'm not talking about one implant, but that is how we go because we are familiar with the system. And we lock one of the rods. We lock.
Yeah.
The other rod, the other one is kept unlocked.
Yeah. But it will be inside
At
the domino.
where the domino is.
Yeah. Okay.
Where the domino is, and we have seen that the correction is remaining, and even with lesser number of distractions, the child actually grows.
Okay. So you mean to say that you um, you don't lock the domino, but the domino is in place where
So we
you
the screw
open
is
and
kept
do a
inside.
distraction. But how do you distract and hold it then? So you do a distraction without locking the domino. You can't hold it like that, no? So understand what I'm asking?
Yeah, I understood. See, one part of the
So one domino you lock and the other one you don't lock. That's what you're saying.
Then what happens is we follow up with the X-rays and see that part of the rod which is not locked, the child is gaining in height.
Yeah.
No, I'm not talking about distraction. Even without distraction, that's what I'm telling. There's
Okay.
as
So
the
you are
child
saying
grows,
something like a Schiller technique, like you put the domino, you don't lock the domino, so you see the growth.
If
Something like that.
when we take X-rays at 6 months or 8 months, and if that part is not growing, that means we will have to go in and distract and then lock.
Okay. Okay.
Otherwise, we tend to follow up these patients without distract. This is working well for the last maybe last 2 years. So that so the number of distractions has come down a bit.
Okay. So you do routinely at 6 months distractions?
Yeah, routinely at 6 months, but we follow the X-rays also. If it is auto distracting, if the rod and the domino, the length is reducing, that means that the child is growing and the rod is also getting lengthened.
Okay. So if it's not happening, you go and distract. That's what I
Yes. If it's not happening, we go and distract.
Okay.
That is working. I think that's working.
Okay. I got your point, but if it's not working, you go and distract, and we can't hold the distraction.
No. At that time we lock.
Yeah.
We know that this is not happening. At that time we lock.
Sure.
Okay.
Got it. Yeah.
At that time we lock. We know that this is not working in this child. So at that time we lock, and then we go for the conventional distraction. But there are some children who will not require locking.
Okay. So
they grow, and I feel that the concept of autofusion is a bit far-fetched because we don't see. We have gone in cases where it is done from outside, and also we have repeated the surgery, reverse cases when we have found that all these patients do not autofuse.
yeah.
See, if you see the Median's technique, Median is not at all a submuscular exposure. It is a subperiosteal exposure. In all his cases of when he is doing this H technique, it is a complete subperiosteal exposure. It is not a submuscular exposure.
Yeah.
So,
but
sometimes
if you see his series, it's most of the series. What he showed is only of neuromuscular and spinal muscular atrophy cases.
True.
All that.
True.
Yeah.
Maybe.
Had cases, Yeah, these curves are very flexible, and the magnitude of the curve will be great, like 90, 80, 90 degrees. But once you put the rods and you put the submuscular wires and pulls it, it comes almost like 10 degrees. So that much of correction is able to get. But only thing is, these child don't have much more growth potential. Suppose we does it at 13 years of age, another 3 or 4 years only they're going to grow, or at the maximum 6 years. So that's what.
But actually, in his technique, is the sublaminar wires are used to derotate the vertebra.
Yeah, pull it. Yeah, derotate and pull it.
To derotate the vertebra. So there is a considerable force that is being applied on the on
That's
each
the
vertebral
same question Guru had regarding periosteal exposure and then why it's not getting fused. Probably because the nature of the child, that is the nature of the etiology, and the age plays a role there. That's what I feel.
True.
Yeah. Any more questions now? I'm not able to hear you, Ram. I'm not able to hear you.
Hello.
Can you hear me?
Yeah, now I'm able to hear you.
Yeah. One question from a participant of Prabhu is asking about the length of rod that has to be left above and below in Sheila technique. Do you decide anything based on age, based on the amount of growth?
Yeah, that is based on how much of growth left for that child. As you see, it's an approximate calculation. How I showed you the second slide about the growth potential. So if you see here, so if the age of the child is say 10 plus years, then you may have another 5-6 centimeters growth left at the age of say 12 or 13. So that much you divide into 2, and then you have to leave it above and below. It's only approximate thing. You can't calculate it perfectly and then rods. So that's approximate guide. Yeah. Okay.
Vijay Raghavan wanted to ask some question. Dr. Vijay Raghavan.
Hello.
Yeah. Hello, sir.
Yeah. Regarding hemivertebra excision, what is the earliest stage would you like to operate? If you see a unsegmented hemivertebra at 1.5 to 2 years of age, will you wait for some time or earlier you operate?
3 or 4 years, that's the age, because you need to hold it with something, right, above and below. So people have operated even at 2 years of age, but ideally about 3 or 4 years, because you need to put some anchor above and below and then crunch it. So I would do it about that time. But yeah, sharps, angular deformity, you do that way at 3 or 4 years.
And on the upper limit, like in 7 or 8 years, will you try?
See, I think beyond 6 years, usually people present to us late also. So at that time, you may have to go a segment above and below extra. You can't do it with one segment. So suppose if it's an 8-year-old child and the deformity has progressed significantly, you can't just do one above and below, because the growth. See, the thing is, the idea is you excise the hemivertebrae in a thinking that the growth potential left is so much. You do it early and then allow you're not doing a deformity correction there. You're doing a fusion and then allowing the above and below segments to grow. So if you go beyond 6 years, I think you have missed the bus on that indication. Beyond that age, like 8 years or 9 years, you should be thinking of getting excision. At the same time, use some distraction technique if you are not ready to go for a fusion. Up to say, if you are going to do a fusion about 2 or 3 levels, especially in the lumbar spine, then you're going to take away all the movements of the lumbar spine. So I would like if it is in the thoracolumbar junction, then I would do a 2-level fusion. But beyond that, I would excise it, do a rod, growing rod or something, and then go for a definitive fusion. That's what I would.
Okay, thank you.
Dr.
And
Vijay,
and
can you
regarding
introduce
casting,
Yeah,
hello.
yeah.
Regarding casting, like what is the interval of casting, and will you always do it under GA, or even in awake patients you try casting techniques?
The recommended technique is under GA with traction suspension. You do it. That's when you get the. You have to give traction. The child suspended with um, uh, belts and rods, and then you do the
Okay.
thing. That's the thing. Yeah, that's the ideal thing to do. I don't recommend doing it on the OPD basis. It doesn't work much unless it's a brace where you want to, if it's a 20-degree or a 25-degree curve, you can measure a brace and then do a something like a alkathene shell brace. That you can do, but not casting. Casting, I think you need to do it on the GA. If you want to do a good molded one, yeah.
And the casting interval, how frequently you change it?
Every 3 months.
Yes.
2 to 3
Okay.
months. This depends on the cast, how much they are able to take care of the cast and all that. Yeah.
Okay. Okay. Thank you. Thank you.
Vijay, can you introduce yourself? You're from?
I'm a consultant spine surgeon in Chennai, MGM Hospital.
Yeah.
Yes.
Anything else? I think we are about to end this.
Hello.
Yeah.
Yeah.
Thanks for joining us, Jeremy.
Oh, thank you.
Yeah. I think if there are no more questions, I think it's time to end up now. That was a well presented talk, Dr. Prince.
Yeah. Thank you, Ram. Thank you for all the active participants and the questions.
Thank you. Bye. Good night. Good night.
And thanks.